this PowerPoint will discuss delirium, an acute state of impaired cognition. Delirium is the most common psychiatric disorder of hospitalized clients. It is important for us as nurses to identify clients at risk, to recognize symptoms of delirium early so we can collaborate with the HCP and ensure prompt treatment. So there are many things that can cause a delirium, and things like dehydration, electrolyte imbalance, infection, they come to mind quickly. But what about uncontrolled or prolonged pain? I had an experience this summer where I had a torn meniscus and I was in a great deal of pain for about 6 weeks before I could have it repaired. And as time progressed and every day I woke and I still had the same pain, it really made a difference. It affected my sleep patterns. I was drowsy, I was irritable, and so you could really apply that to possibly an elderly client who comes in for surgery and doesn't have their pain managed post-op, and can see how that could have a negative effect on them and possibly cause a delirium. It's important to think about substance abuse, but also the withdrawal of substances. So this fall you'll have a really great SALT lab about a client who is in a state of withdrawal from alcohol. And so very often we can see that these clients will experience a delirium as well. So who is at risk and what is the risk? Well, the elderly are at risk. Couple reasons. One, they have what we call a decreased biologic reserve. So they're much more likely to dehydrate quicker than a young, healthy person. The other issue that we see with the elderly is called polypharmacy. And polypharmacy means that they take several medications that may interact with each other. A great example is you have an elderly client, they go to their healthcare provider, they receive a few prescriptions. They go a few months later to the endocrinologist, and then 6 months after that to the cardiologist, and maybe they also see the foot doctor in between, and they collect several different prescriptions. I've seen it happen more than once that I've admitted a client who has a prescription bottle that says Lasix and one that says furosemide, and they came from 2 different doctors and 2 different pharmacies. And so nobody's looking at the big picture. The client is taking a double dose of a diuretic, they've fallen, and they've broken their hip. And so this is an important thing to look for in the elderly. We think about clients in ICU as well. There's a phenomenon called Icu Psychosis, and clients can experience this because the lights are always on. They have a hard time telling is it day or is it night. Very often they're intubated, so they can't communicate verbally, and so you can see how they could very easily become confused in their environment. What is the risk? Well, safety definitely. Falls, safety that leads to falls and injury. Also nutritional deficits. Clients who are in a true state of delirium probably don't have the attention span to sit and finish a meal. So prevention is key. A couple of points that I'd like to make. Promotion of sleep and rest. I can give the example of having a newborn baby in the house, and those of you who have had that experience know exactly what a lack of sleep can do to you. Also, clients that have sensory deficits, such as a visual or hearing deficit, how important it is to make sure they are wearing their eyeglasses and their hearing aids are on and functioning. What about the client on oxygen? How many times when you are doing your 60-second assessment do you go in the room and find the nasal cannula on the floor or maybe that it's not correctly placed in the nares, that it's aerating the eyeballs. So these are all things that we can think about to put the client in the very best possible state to prevent the delirium.
Diagnostics are important in the care of the client with the delirium because remember how important it is for us to find the cause so it can be treated. So lab values are very important. They can determine if there's evidence of infection. We may be looking at the white blood cell count. We may be looking at blood cultures. An electrolyte imbalance could be an important clue. It might tell us, for instance, if a client is dehydrated, something that happens frequently with the elderly. Or we may look at, is there a drug toxicity? We may want to look at brain scans such as a CAT scan or an MRI to determine, has there been a bleed, a brain bleed, or is there a tumor, a brain tumor that might be causing this temporary confusion? It's really important that once we discover the cause in concert with the healthcare provider and the cause is treated, that we as nurses make assessments to evaluate, is the client getting better? And so some of those assessments that we can use are the mini mental status exam or mini mental state exam. So sometimes you see the word status and sometimes you see the word state where this exam is concerned. So I wanted you to have both titles. Down below in notes, it will show you in your text where you can see an example of both this exam and the mini cog, and they can certainly be used to reassess a client with delirium as we're looking for that expected outcome of return to baseline. Remember that the full MMSE is posted in Blackboard for you under Learning Materials. The CAM, or the Confusion Assessment Method, is another diagnostic tool or cognitive assessment that's really specific to delirium. And it really can help you to make an assessment of that fluctuation of behaviors that I talked about on the first voiceover. And so is there a range that goes from hyperactivity to somnolence? I did put a link in Learning Materials in that folder for the CAM. And again, below in the notes, your textbook does refer to it and give a little bit of information about it. And then lastly, the Geriatric Depression Scale, which is not in either text. It is used to rule out depression in the elderly that may cause a misdiagnosis of dementia. Again, that is also provided for your reference in the folder on Blackboard.
So what are the signs that we see in our clients with delirium, or the clinical manifestations? Well, disordered cognition, difficulty with reasoning and problem solving, rambling speech, disorientation, hallucinations, delusions, what we call labile moods, going from happy to sad very quickly, altered perceptions. You've seen this. This is the client who's reaching for something that isn't there or picking at something in the air. An attention deficit, a disturbed sleep-wake cycle, alternating between periods of lethargy and drowsiness and hyperactivity. Psychomotor disturbances. So clients with delirium can have many of these or one of these, but these are a variety of some of the symptoms that you would see. So when we assess clients with delirium, it's very important that we take a good history. Because it's important that we identify the cause, or because we want to identify clients at risk, a good history is essential. So we may ask the client, or we may ask the family member or caregiver that presents with them. Things like, has there been any trauma? Is there any substance abuse? Has the client started new medications? Or has the client stopped taking their medications? What is the client's usual status like? Have there been personality changes that you've noticed? Mood swings? Does the client have a problem with problem solving or an attention span deficit? All really important questions that can help you to drill deeper. What is the client's functional status like? Are they able to perform their activities of daily living? Here are a few nursing diagnoses that are relevant to a delirium. This is also a good time probably to refresh the makeup of your diagnosis statement. So remember that we need a nursing problem, which is a NANDA diagnosis. We need an etiology or cause, and we need some evidence of the nursing problem. So acute confusion speaks to a delirium related possibly to the effects of medication. Perhaps you have a toxic drug, serum drug level, and the evidence may be decreased attention span and intelligible speech. Another problem, risk for injury. Remember that risks for anything do not require evidence. It hasn't happened yet. You're just worrying about it. So in this case, you may have a risk for injury related to an impairment in cognitive and psychomotor functioning. For client outcomes, it's also a good time to refresh ourselves and remember that they must be client-centered. So we'll say client will. They must be measurable and time referenced so that we can evaluate them later. So, for example, a client with a self-care deficit, we could say they will accept assistance with ADLs this shift. We might also want to look at something more long-term and say the client will perform ADLs independently prior to discharge. Nursing interventions for clients with delirium are largely about managing the symptoms. So first let's think about the environment that a client is in. If it's possible, we want to decrease their stimulation. Being overstimulated is going to add to their delirium and exacerbate their symptoms. So if possible, things like a private room. Playing soft music versus the television. The television can be a means for misunderstandings. A client may hallucinate or have a delusion based on what they're viewing on television. It's important for these clients to have the support and the comfort of family and what's familiar to them. So having a family member stay or having a photograph by the bedside is helpful. And we can certainly reorient with things like clocks and calendars, but for the client with a delirium who has an attention deficit or a psychomotor problem, it's very often easy to just use signage. So perhaps a sign on the bathroom door of a toilet or a commode. As we continue to think about nursing interventions and managing symptoms, we can look at cognitive interventions. So one thing that's very difficult for a client with a delirium is concentration. So it's very important for us to think about very clear, simple instructions. Overwhelming them can exacerbate their symptoms. Reorienting and using therapeutic communication are important. Calling them by name is a great way to reorient. Psychosocial aspects include the care of the family member as well. So we need to do some teaching. Generally, clients don't understand what's happening to them. They may be afraid or anxious. So providing support, explaining to them this will resolve, and thinking about compassionate care. One example that works sometimes for clients who are very agitated is to produce an activity for them where they can employ a repetitive motion, such as packing and unpacking a bag or folding linen. And this routine, repetitive motion is somehow a type of comforting structure to them. It doesn't always work, but sometimes it can. We try to use antipsychotics as a last result after we've tried everything else, because adding more medications to a client with a delirium may not always have the best outcome. It's important for us to provide the safest environment as possible, and remember that providing a safe environment is one of our CUSIN initiatives. You remember the CUSIN is the Quality and Safety Education initiative for student nurses. So certainly things like putting their personal items within their reach are great, but let's go a little further and think about the client who is wandering. Do they have a bracelet on their ankle, and is there an alarm system on the unit? So it's important to make sure frequently that the bracelet is in place, to observe the client frequently. Bed rails may pose a danger to the client, especially one that has some psychomotor activity. They could potentially get a limb stuck in a side rail, or worse yet, suffocate themselves. Avoiding restraints is important too, because unless the client is really at risk of harming themselves or others, the use of restraints may lead to an injury. It's important that we assist them with their activities of daily living if they can't perform them themselves. They should, with resolution of a delirium, return to baseline and baseline function, but in the meantime we must meet their physiologic needs, and remember, physiologic needs are important and very basic on Maslow's hierarchy of needs. Because nurses don't work in isolation, it's important that we collaborate with our team members. So regarding the medical providers, it's important to think about, are they holding medications? Should we be evaluating the effect of that, collecting the data and reporting it back, allowing them to make decisions on treatment based on our astute assessments? We can support all disciplines by helping them to promote safety awareness as well. Nurses teaching in delirium is important. As I said earlier, clients can be afraid, they cannot understand what's happening. Family members don't understand why the client is perhaps acting that way. It's important for us to explain this is a temporary condition and provide progress reports routinely to the client and the family to help rest their fears. So how do we evaluate the effectiveness of treatment for a client who is experiencing a delirium? Well, what we're looking for are reversal of those symptoms. Things like an improved mini mental status exam score, an increased attention span, reduced behaviors, such as hallucinations or delusions, are all signs for us that we can say that the client is responding well and the delirium is in fact resolving.